Terrific. Well, we have kind of a lot of information to cover this morning, so we'll get going and introduce ourselves and our presenter while folks are still jumping in. So thank you for joining us, and welcome. For those that I haven't had the pleasure of meeting, I'm Lori Bellingham, Vice President for Community Impact at Adirondack Foundation. And for those who may not be deeply involved with Adirondack Foundation and ADK Action, Sawyer, do you want to kick us off by sharing a little bit about ADK Action?
Yes, thank you, Lori, and welcome everyone. Thank you so much for joining us today. As Lori mentioned, my name is Sawyer Cressup, and I'm the Executive Director of ADK Action. We're a nonprofit that was founded in 2011, focused on community development and sustainable environments in the Adirondacks. Our projects range from fighting food insecurity by increasing access to local food to promoting practical and safe applications to reduce road salt, conserving pollinator species and increasing habitat, fostering expanded access to broadband and housing resources, and the list goes on. But the through line through all our interconnected initiatives is meeting unmet needs in the region for people and nature. And our founding belief is really that a small group of passionate people can make a difference on issues that matter. And I'm so thrilled to see so many change makers in the region in the room today. Lori, do you want to share a little bit more about the foundation?
Sure. Thank you, Sawyer. So Adirondack Foundation's mission is to enhance the quality of life in the Adirondacks through philanthropy, today, tomorrow, and always, by focusing our resources, so our time, talent, and dollars. We enlist powerful partners like ADK Action and provide leadership. We're making great progress addressing the region's intractable challenges. The foundation is a collective of many charitable funds that reflect the diverse ways that people choose to help their community or the region. Donors can make unrestricted gifts that meet community needs, or they can establish permanent or flexible funds that address their philanthropic interests. These funds grow over time, addressing through annual grants the donor's dream of a better community. So since our founding in 1997, our assets have grown to approximately 81 million, depending on what the market's doing at any given time, through our donors' generosity, creating an enduring resource for our community that continues to grow. Over the past 25 years, this charitable investment has given out more than 72 million in grants to nonprofits and other community institutions to help our region thrive. Through strategic grant making and leadership, the foundation plays a key role in identifying and solving community problems such as food insecurity, lack of childcare, housing shortages, barriers to college, limited access to vocational training, and threats to economic vitality. And as Sawyer said, the list goes on. I'll hand it back to you, Sawyer, to share a bit more about how this webinar developed so we can get going.
Definitely. Well, Lori and I come from organizations that seek partnership and work to invest in taking action on some of our region's greatest challenges. And we were heartened and interested to learn more about the 1115 waiver, specifically the apparent shift and recognition of the blending of social drivers of health and healthcare. Given our rural region, we're particularly interested in how community-based organizations who have not participated in the Medicaid process before can better understand it and can become involved so we can all better serve our community. And as this opportunity develops, we wanted to make sure every organization had the information they needed to prepare themselves and their operations in hopes of better serving the greater Adirondack Park and to help everyone access this topic and position ourselves towards partnerships as the time allows. Along the way today, we hope that you'll share some questions in the chat when we conclude our presentation. We're going to turn things over to Scott very shortly, and then we'll have some time saved at the end to address questions that arise. And we're truly lucky to have Scott with us today. He's such a wealth of knowledge on this topic. Scott Emery is a partner at MS Hall & Associates, a healthcare consultancy where he established and oversees the strategy and transformation team. Scott was heavily involved in the New York State DSRIP program for the entirety of its 5-year timeline and has worked across the public and social spectrum, designing innovative projects, organizational models, and multi-stakeholder collaboratives in New York and elsewhere. Scott and his team have been really integral partners with organizations across the state since the 1115 waiver concept paper emerged in August of 2021. And in particular, Scott pursues the advancement of systemic equity and community resilience through his strategic design work. This means helping others better see themselves, their context, and how to create their future with holistic approaches to listening, decision-making, and solutions development. And I think he's really the right person to help all of us learn about this fairly complex topic. So with that, Scott, I'll turn things your way. Welcome.
Thank you, Sawyer. And Lori, it's nice to see everyone. I know some faces. I can only see some right now without scrolling through all the rest of them. I will try to pay attention to all of you as much as I possibly can, but as Sawyer and Lori said, there will be some time at the end for questions. So today what we're really going to do is just do an overview of the entirety of this thing called the 1115 waiver. I'm going to share my screen here in a second. We're going to go through some slides. But really the goal of today is to give this overarching first steps for some people. I know that Lori and Sawyer sent out and had some questions to be perhaps asked ahead of time, and we'll get to some of those. But thinking about where do we find ourselves, how did we get here, what's the content of this 1115 waiver, and how should we begin to perhaps think about it as a collective as to where the Adirondacks might be needing to go. So all that said, I'm going to share my screen and take the dangerous next steps of sharing the correct screen. And if I hit play on this, hopefully everyone sees the big slide first. Yep. Okay, fantastic. Pressure is now off. Okay, so we are going to talk through the New York Health Equity Reform. Perhaps you've heard this under the name SHERPA. We're not going to go through all the different acronyms that have been part of this process, but we're going to talk about what is it that the 1115 waiver contains and what is it the state is trying to do. First of all, and it's already been sort of said, MS Law & Associates, we are a consulting firm here in Syracuse, New York. We work all across the entire state and elsewhere. I head up our strategy and transformation teams, and we work with organizations across public and social sectors, health and equity, community-based, philanthropic, governmental, educational organizations. All of those are our clients. The reason why we spread ourselves across that spectrum is that we believe that a lot of our work is introducing people to the connections that are already there. A lot of our work is systemic in nature, and a lot of the things that we believe in have to do with interdependency and how do we actually bridge some of those chasms that have historically been siloed, especially when, if it's all connected, we need to be thinking about these things together. So again, as Sawyer put very, very well, and that was great, a lot of our work looks like creating collaborative spaces for bold dialogue in order to make courageous choices aimed at the advancement of systemic equity and community resilience. Part of why we've been so adamant about getting this information out into the public is because this seems like a great opportunity towards those end goals of community resilience and systemic equity. And so obviously we'll talk more about what that looks like. But what we're going to talk about today, if I could say anything to start off with, really where we want to try and get to is thinking about how can we leverage this 1115 waiver towards the ends that we are already trying to accomplish, and perhaps not the other way around. We'll talk more about that here in a second. So just a quick glance of some of the things that we have done. We've done a lot of fun projects. We've helped build a housing trust fund, thinking about how can we aim at those most vulnerable for displacement. We've helped develop a women's wellness center in an urban neighborhood primarily comprised of resettled refugees and new Americans. We've done a lot of fun things across housing, food, transportation. And in that upper right-hand corner is this thing that perhaps is going to send some chills down people's backs, but perhaps not. But thinking about, we were heavily involved, as Sawyer alluded to, in that New York State DSRIP program, which we will allude to a little bit today, but make some stark contrasts compared to what that is. So just to kind of give a feel for some of the work that we have been doing, aiming at systemic equity and community resilience. That said, let's begin to dive into this information. As was already said before, you're going to get all these slides. So don't feel like, as we're kind of doing like the fire hose, that you have to write these things down. If you want to write them down, if that helps you capture those thoughts, please feel free to do just that, but don't feel like you have to. So, overarchingly, the state has requested $13.52 billion over a 5-year period. The overarching goal here is trying to fully integrate social care and healthcare into the fabric of the New York State Medicaid program. So this is a healthcare program, but the Department of Health does not have the market on health and health equity. So when I talk about these things, I generally want to preface this with thinking about if we're trying to integrate social care and healthcare into the New York State Medicaid program, we're going to talk an awful lot about what have historically been called social determinants of health. You will see in here things like social care needs, and now the most recent iteration of these things are called health-related social needs. We'll use those interchangeably. I'll also try to be very cognizant, and I'll say this right now, just so I don't forget. I will try my best not to use acronyms, and I will try really carefully to make sure if I do say something that I catch myself and give the full name of what that might be. But overarchingly, the state is trying to integrate social care and healthcare, and so by doing that, it's going to involve an awful lot of parties because of what that looks like in reality. So the 4 bullets here are the goals underneath that overarching goal of building a more resilient, flexible, and integrated delivery system that reduces health disparities, promotes health equity, and supports the delivery of social care, developing and strengthening transitional housing services and alternatives for the homeless and long-term institutional populations, redesigning and strengthening system capabilities to improve quality, advance health equity, and address workforce shortages. The main emphasis on that one is more of the workforce side of things, a very big topic right now. And then lastly, creating statewide digital and telehealth infrastructure. So we're going to go through those 4 goals in a decent amount of detail. The goal here is not to overwhelm you, but to give you the information so that you can take it and do with it what you will. So there'll be a lot, but I want you to know that that's on purpose so you can utilize these slides as this is what this thing's trying to get at. So one of the first things that we want to talk about here is that when the state has gone through its iterations of submitting and putting out there the concept paper back in August of 2021 to where we find ourselves now after having public comment periods and things like that, one of the first things that stood out was if we're calling this thing and putting it and orienting it around health equity, we should probably define what we mean by health equity. So this is what the state has adopted. It's the Robert Wood Johnson Foundation definition. And it states that the idea that everyone has a fair and just opportunity to be as healthy as possible, which requires removing obstacles such as poverty, discrimination, and their consequences, including powerlessness, lack of access to good good jobs with fair pay, quality education, housing, safe environments, and healthcare. We will talk about some of those specific things like housing and whatnot later on, but this is what has been adopted by the state as far as its definition of health equity. This is generally where I want to also state that I am not an agent of the state. And so there will be things in this presentation that you might have questions about or concerns about. I'm just going to say right off the bat, Scott Emery does not work for New York State Department of Health. And so therefore, there might be some things that will be more Scott Emery focused and other things that are the state, and I will try to differentiate if there are questions about those different things. So this is what the state is going with for right now. So why is it doing this? Lots of different reasons. Some of them are lessons learned from DISRIP around regional alignment on objectives, more direct investments in community-based organizations addressing social care needs. But a lot of this also stems from the reality that COVID has enhanced and put a lot of the things that we're going to talk about as far as social care needs, social determinants of health, really on a different level than perhaps what was experienced before, especially for more marginalized communities that have been experiencing these things for decades and decades and decades. So essentially why a lot of lessons learned from Disrupt, a lot of the things that have not necessarily been new because of COVID, but have been accentuated and amplified because of what has taken place around that. A few caveats. This is not Disrupt 2.0, or if you're familiar with how that whole thing shook out 3.0, it's a different direction and it's doing things in a different way for the sake of differentiating itself, but carrying on in some of the lessons learned. It's the state showing its health equity cards and its determination to go in this way. So again, if you're familiar with some of the things that have happened over the last several years, there's been a lot of emphasis on very common material and direction from the state in what is found in this 1115 waiver. Community-based organizations will play a central role. And this is one of the Scott Emery things, not a state thing necessarily. I believe that success will be found where networks of trust are made visible and expanded. And that's a key thing that we will certainly talk about today, but then certainly into the future of thinking about if we are addressing a lot of the things that happen in the social care side of things and healthcare side of things. It is the job of networks, it's the work of networks to actually build trust around a lot of the challenges that are in front of us, because that is where, if progress moves at the speed of trust, collaboration moves at the speed of trust, these are the things that are oftentimes the hardest parts to put on paper, but are the glue that stick these things together. So it's not just a continuation of previous efforts, it's really a recalibration as it integrates social and healthcare into this creation of a new status quo. So let's now start get into a bit of the details as to what this thing contains. So under that first goal of building a more resilient, flexible, and integrated delivery system that does these different things, the first thing I want to talk about are these things called HEROES, Health Equity Regional Organizations. So this is not a PPS, a performing provider system of Disrupt. It's different. These are mission-based organizations with a state-designated lead entity. So there will be a procurement process. There will be organizations vying for taking on this title and the responsibilities that come with it. We'll talk about that more in a second. But it's a mission. These are mission-based organizations, the state-designated lead, that will build a coalition of a variety of organizations that will be regionally focused in order to align with health equity needs that differ by community and future value-based payment contracting structures. So mission-based organizations with a lead entity chosen by the state. They're going to build out a coalition of a variety of organizations, a diverse set of organizations within a region. So they'll be regionally focused and focusing on health equity needs and future VBP, value-based payment contracting structures themselves. So what do these HEROES, Health Equity Regional Organizations, what do some of these things look like that we know about right now? You will see in this part, these different portions, some highlighted parts. That is because these are things that have been more recently added based on the public comment period that has already taken place here in the state. So what's the representation and governance within the HERO look like? It's really that coalition of a variety of organizations. So they want to see not just healthcare, not just social care, but really MCOs, managed care organizations, the insurance companies, hospitals and health systems, community-based providers, a whole slew of regional organizations, all attending to what's happening in their regions. A couple of the highlighted portions, tribal nation representatives, providers serving complex children and families, and then consumers, including those with lived experience around a variety of different things, and caretakers. So even down to the individual Medicaid patient or patients, they want to see this be a diverse local set of organizations and potentially individuals helping to add to the diversity of perspective as to what's happening in a particular region. So this will also be funded in their different capabilities. So overarchingly for the entirety of the 5 years, the HEROES, the Health Equity Regional Organizations, will be on the receiving end in total of $293 million over that 5 years in the form of limited planning grants. And so if you know what happened back in the days of Disrupt, this is a very different thing, thinking about all of the heroes will receive this amount of money in the form of limited planning grants for the main responsibilities that they will have to carry out, which we'll talk about here in a second. But part of what they should be able to do capability-wise is receive and ingest data from a variety of different sources, assume it's necessary regional planning focus to create collaborations, and help develop a range of EBP models or other targeted interventions. So a lot of this is what they're going to be getting at are these responsibilities. A big one is developing these annual regional plans. So what does it look like with a diverse set of organizations coming together to look at the region itself and come up with these annual regional plans over the course, one per year over the course of the 5 years, and identify and begin to think through what do we need to be doing as far as these social care needs in our region? How do we identify them? How do we assess them? How do we begin to think about the natural collaborations that perhaps already exist attending to these different areas? A lot of different things that have to do with what do these annual regional plans look like? They will have to be utilizing data from state-developed uniform social care assessments. This was a little bit of a confusion point, hence why it's being highlighted. The state will develop this uniform social care assessment, and the heroes, the health equity regional organizations, will be utilizing that data from the results of the actual assessment itself. They'll be going forward together with a diverse set of organizations for the sake of measurement selection, including measures stratified by race and ethnicity, and other optional measures that are in there, developing these targeted EBP interventions. And then right now, per what we know, the ultimate objective of the heroes is to inform the continued movement to more advanced EBP models. A lot of what this is trying to understand is how do we create different mechanisms to keep the things that are allowing us to attend to the social care needs of our region. How do we undergird those or include them in more robust value-based payment models and things along those lines? But a lot of this is thinking about the annual plans and what's going to be taking place there. So when we think about the HERO, the Health Equity Regional Organization, this is a different thing than the PPSs of DSRIP. They are much more diverse in representation and governance, a very different set of funds and a very lower amount of funds overarchingly. And then these annual regional plans and thinking about more VBP interventions and what that looks like around social care needs. Those are the main responsibilities. And so when we think about health equity regional organizations, we should be thinking about things like planning and strategy, things of that nature. The other entity that the state wants to see come into being, which we'll talk about in a second here too, these social determinant of health networks, those will be more of the execution and implementation around what's being planned for over the course of these 5 years. So, regional plans, a little bit more detail here, thinking about a holistic value-driven approach to evaluating and addressing the needs of vulnerable populations in a financially stable and efficient manner through value-based payment. Must include a needs assessment of the key communities in the region, develop a mission-driven framework, identify specific actions and initiatives, and act as the central hub of data infrastructure, thinking about how are we identifying, assessing, and moving forward with the different social care needs of the region itself. So the regional plan will be encompassing a lot of these different components that there's still a lot of detail that we don't have just yet. And so hopefully we will have those as we continue to move forward. We'll talk more about that here in a second. So I've said region or regional probably a dozen times at this point. One of the things that we don't quite yet know or don't have a solid answer just yet is what that regional breakout will look like. Again, if you've been following all of this, there's been a lot of different back and forth over the last year and a half-ish now, or however many months it's been since August of 2021. There was this map and then there was that map. There was this, perhaps this is what was announced in the public hearing. There was a public hearing on May 3rd, and the state said, here's what we're going to be moving forward with. After that, and as a response to public comments that took place on September 2nd, they said, well, we're going to hold off and not actually determine these regions just yet. More information will be coming. So when we look at the map that we have in front of us from May, it maybe gives us some kind of insight into what might be happening, but not necessarily. I've been asked a million questions about this. essentially, I will just say anything about this would be speculation at this point, and so more on that to come as we are thinking about this. However, we do know, or at least it's in the documentation, that there will be one hero per region, but we'll see what that actually begins to look like when we get this regional breakout later on. So when we think about the fact that the state is going to be putting forward a procurement process and identifying a lead organization or organizations for that hero, that will be one per region, depending on how the regions actually flesh themselves out. So more on that yet to be determined. So the second entity that the state wants to see come into being and get the title of are these social determinants of health networks. So I might accidentally refer to these as SDHNs, but I will try to continue to say out the full title. So social determinant of health networks will consist of, in the same manner as the hero, a state designated lead. So there would be a procurement process, there would be choosing, and that lead will lead the social determinant of health network with a network of community-based organizations behind it or alongside it within each region of the state. So right now it's looking like if there's a hero, there's an SDHN, a social determinant of health network. They should be working in tandem. The social determinant of health network will be a part of that diverse set of organizations. The planning that takes place at the hero side of things will be tied to the implementation and execution of what happens on the social determinant of health network side of things. So this network will collectively use evidence-based interventions, and we'll talk more about this second part, or other DOH approved interventions on a pilot basis to coordinate and deliver services to address a range of social care needs that improve health outcomes, such as housing, food, transportation, interpersonal safety. That last list of things is a sample of the different areas that the state's really been focusing on for quite some time. Again, it's showing its cards that it really wants to hone in on specific domains of social care needs, and we'll talk more about that in a minute. But social determinant of health network, it's not the hero, it's separate from that. It's not a performing provider system with days of disrep. It is a separate entity working in conjunction with the hero, consisting of a designated lead, a network of community-based organizations, using existing evidence-based interventions or some piloted ones approved by the DOH to essentially address and deliver services to a wide range of social care needs within the region that it is responsible for. So, again, this is different in representation and governance. It is a network of CBOs, community-based organizations, with a state-designated lead. Funding and capabilities, they will have, for in total, $860 million over those 5 years. They will receive direct investments to develop infrastructure necessary to support. So the social determinant of health network will be on the receiving end of funding to think about IT, business processes, things like that. Community-based organizations will also receive funding necessary to integrate into the network, provide services, develop infrastructure, things along those lines. So if you are a community-based organization attending to housing, transportation, all of those different areas, and their indirect corollaries that are all part of that puzzle, there is the possibility of receiving funding necessary to essentially play in that network and be successful by developing further things, including infrastructure. And then there will be some kind of mechanism where CBO funding will be tied to deliverables around the population served, but more on that we don't know right now. There's a lot of things that are still being negotiated. We'll talk about that in a minute. And when things move forward, we will get these things called the special terms and conditions, which nerds like me read through on vacation and begin to parse out what's actually taking place here that will give us a lot of those nuts and bolts to say, oh, okay, this is what that means, or this is the more detail that we didn't have prior, things along those lines. So funding and funds flow questions, we don't know right now. So feel free to ask, but I will probably say something like this. More to come. So responsibilities, they're going to formally organize community-based organizations to perform these interventions. The newer part here, again, that I referred to on the previous slide, is that the state has, because of public comment, essentially given us a little bit what seems to be an open door to develop interventions on a pilot basis have to be approved as to how the language talks about it now by the DOH. What that process looks like, don't know. But this seems to be a lot more descriptive in nature than prescriptive. And so if that's the case, I know from the conversations I've been having all over the state and from the work that we're doing already, helping develop social determinant of health networks and heroes, there are questions about, oh, okay, well, how can we begin to think about that? I think it begins in thinking through what are the actual needs of the community. When the state says, hey, this is actually a thing we're going to push forward, we have this approval, there will be things like all of this information that the state will say from the top down, more or less, $13.5 billion, 5 years, heroes, SDHNs, those components. Part of this is to begin to say, how do we meet that from the bottom up with the actual needs of our community? How do we make visible the different things that go into things like, good paying jobs, workforce development, transportation and security, food, all these different components. I know I've been having conversations with folks who are saying, we have a lot of this already moving. We've already been building on this for decades, which is 100% true in all sorts of cases. We know we need to have steel-toed boots for people to actually have these things take place. The connector piece here, the missing part, is literally steel-toed boots. Okay, great. How do we begin to think about those those realities that I'm sure lots of people on this call are very, very well aware of? How do we make those visible and begin to think about, all right, what are things that we could do that perhaps haven't been part of our intervention toolkit in a long time or ever? More on that as we know more of what that would look like. All to say, there seems to be a door open for more descriptive, piloty type of interventions. So again, this will have a referral network tied to it with multiple CBOs and other people and other organizations that are part of that. A single point of contracting for social care needs arrangements in VBP arrangements. And then thinking about what's this look like as far as social care issues and screening and things along those lines. So if the health equity regional organization is more planning and strategy, annual regional plans, things along those lines, within a region, diverse set of organizations, because diversity is our strength. The social determinant of health network is much more of the execution implementation side of it, tied to the hero as far as understanding what's happening, but then carrying out those different interventions, evidence-based, and this potential, what's it look like as far as pilot approved by DOH. Investments are going to go to the social determinant of health network itself and CBOs to be able to participate in these things. A lot more there that's still yet to be made known to us, but this is where the state's trying to go. So part of this is the social care data interoperability exchange. Part of this conversation has been that the state was looking to do a different set of procurement processes to get one platform to rule them all. They've gotten away from that. They're moving forward with the SHINY, the State Healthcare Information Network of New York. If you are familiar with your, I'm going to say a bunch of different acronyms, your RIO, your Regional Health Information Organization, or your QE, your qualified entity, there are different things that all kind of get to things like Healthy Connections or HICSNY. There are different groups who are doing this work on the healthcare side. The state wants to begin to put these things together to understand healthcare and the social care needs, referral platforms, things along those lines. A lot is yet to be seen for this, but the state is trying to move these things data-wise towards a much more common understanding and common platform, or at least connected platforms, for the sake of understanding what is actually happening at the regional level. So again, the different areas that the state has been looking at and has been saying publicly for a long time, as have a lot of other states. If you, and I know you all have, been staying up on your other states' 1115 waiver progress reports, there have been a handful of different states who have had their 1115 waivers approved, essentially focusing on relatively the same types of areas and or in general, focusing more on the social care needs of their states for the sake of its Medicaid population. But these are, generally speaking, the same areas that they've been talking to: economic instability, housing, food, transportation, interpersonal safety, toxic stress, and health literacy and education. So if you are attending to these things directly or indirectly, you're part of existing networks, part of existing, conversations at the regional level, whatever that looks like. This is kind of the main areas the state has been putting forward. There's going to be an awful lot of talk about value-based payments. I know I've already alluded to it several different times. Out of that $13.52 billion, about half of that right now is purported to going into the advancement of value-based payment models. Some of the opportunities here, if you are unfamiliar with value-based payment and how that all works within the Medicaid space, there are certainly education available and things along those lines. A lot of what's being discussed is how can this actually move into perpetuity? Things that perhaps have only been funded or have only had revenue streams around things like grants or other opportunities like that. And so where this conversation is going is, how do the social care needs around the things that we just looked at, housing, food, transportation, all of that, how can those be undergirded perhaps by differing value-based payment models to move those into the future for the sake of keeping them sustainable and whatnot? So there will be an awful lot of talk about this. There will be more about what this contains coming forward. The things I have in here are just some different examples of what the state is getting at, as far as perhaps a global prepayment model, redeveloping this thing called the value-based payment roadmap, and then thinking about advanced value-based payment contracting. Again, a lot more there and a lot of emphasis on that on the financial side. And so we can certainly talk more about that at another time. This just kind of gives a breakdown of what that funding looks like. Again, about 50% of that, because they want to see these things move forward. Another part of this first goal is ensuring access for the criminal justice involved populations. The key things here are thinking about seeking to build and strengthen relationships, ensuring appropriate transition and supports. There will be specific things happening for Medicaid patients who are incarcerated 30 days prior to release. And so thinking about what does this look like? Again, if you are attending to this very specific population, how can you begin to think about what that looks like as this is moving forward for the sake of your region and those folks there? So that's all just the first bullet. Welcome to 1115 waiver. The next things that we're going to talk about as we continue through this are certainly points of emphasis, but there's not quite as much information about these next ones. And so I preface that to say, if you are doing things in the worlds of these next few bullets, there's still a lot more that has not yet come up. So second goal, as they're trying to integrate social and healthcare in the Medicaid program, developing and strengthening transitional housing services and alternatives for the homeless and long-term institutional populations. The thing I want to point out here is that in their early documentation, they had supportive housing versus transitional housing. Due to public comment, they changed that out. And so what they're looking to do here is planning and coordinating, going through those heroes, the health equity regional organizations, conducting inventory of housing, transitional housing programs, matching Medicaid and homeless data in order to further engage and understand what's happening. There are 5 core tasks within the New York State housing gap that are here. If you are in this world of transitional housing, thinking about what housing looks like in the Adirondacks, I know from some of my work in previous conversations and just being a part of upstate New York, housing is certainly a thing in the Adirondacks from what I understand, as far as thinking about the base and the access to affordable housing, the tourism industry, and what does that look like? There are a lot of crossing of what that looks like in the Adirondacks. And so thinking about some of the different parts of what are happening here. There will be this development of this enhanced transitional housing initiative, where there will be dollars put towards what's happening as far as Medicaid or medical respite, referral and coordination of related services and benefits, community transitional services, coordinated care, tenancy supports. If this goes through as it's being proposed with $1.565 billion over the next 5 years, from what I understand, this could be the biggest Medicaid and housing initiative in the entire country because of what they actually want to see here. This is also the only area out of those social care needs that we talked about a second ago, housing, food, transportation, etc. This is the only one with its own separate bucket focusing on a specific domain. So there's not going to be another bucket like this for food or transportation. It's really just housing, which seems to put the emphasis and priority towards the actual world of transitional housing and what is happening there. So a lot more it's going to be looking at this, but this will be tied to that health equity regional organization There would be a lot of different initiatives going back and forth between housing initiatives and what's happening at the level of the hero. So a lot more there for us to continue to think about how do we meet something like this from the bottom up to be able to address what the community is actually in need of. So thirdly, is redesigning and strengthening system capabilities to improve quality, advance health equity, and address workforce shortages. Again, this is the only portion where we will see this part, which is thinking about a pool of money for distressed hospitals and nursing homes. This is the only portion where there is explicitly called out healthcare providers of a couple different types. There will be funding put together for the sake of what's happening. This will not just be a standalone, it will have to be tied to the work occurring at the level of the hero. There are different milestones and different triggering for different funding. It can't just be, hey, we're distressed, give us money. There will have to be a tie to what's happening in this program overarchingly. But this is the only portion where you will see a group or groups called out specifically for this. And this is also the only portion where you will see in the documentation things around workforce in an explicit nature. So there's not a lot, but what the state is trying to do is trying to reinvest in these things called WIOs, workforce investment organizations. They will have to have work happening focused on the region itself, thinking about planning efforts with a variety of stakeholders, and the funds around this will target recruitment, retention, develop and strengthen career pathways, training initiatives, expansion of the community health worker and related workforce, and then the standardization around occupations and job training. The highlighted portion here, again, comes from the public comment period of recruitment of greater participation by people of color, and people identifying as LGBTQ+, in medical professions in the communities that they are serving. That was a specific ad due to the public comment period. Again, all this to say, workforce, I know in all my travels, is a huge, huge topic right now. There's not a ton of detail as to, again, funds flow or things along those lines and what that will look like. All of this will, again, be tied to the occurrences of the hero and things along those lines as far as the annual planning and thinking about what does a workforce look like specific to the context that you are in, i.e. the Adirondacks and what's happening. And then lastly, if COVID did anything, and it did a lot, it certainly emphasized the need for telehealth infrastructure and for the need to be able to overcome geographic disparities and things along those lines. So the state is going to develop this thing called the Equitable Virtual Care Access Fund. It'll be $300 million over the 5 years and looking to do things, these telehealth modalities. This is just a small sampling of what the documentation actually holds. It's a very long list of different options that seem to have some thought behind them as far as things happening at different county level, amounts that could be, and like different tools that can be utilized, things along those lines. I share this list here, but I want to, especially for this portion, say, if you were to go back to the 1115 waiver documentation, this section in particular is going to have an awful lot more there that it's calling out. For the sake of space, I only put these ones. But the state has seemed to recognize the need for telehealth. $300 million over the 5 years is really going to be scratching the surface. So again, how do we think about what's happening specifically in the Adirondacks around broadband access, things along those lines, to meet what the state's going to say from the top with the needs of the community from the bottom, and how do we have different opportunities to be leveraging the 1115 waiver to the things that we know we need to accomplish, not the other way around. So perhaps you're scratching your head and saying, all right, well, all that information is fantastic, but where do we find ourselves? So back in July, just to give a little bit of history, the state announced this timeline. As you might see right there is a January 1 date. That has not happened. Where we actually find ourselves is that the state had its formal submission to the Centers of Medicare and Medicaid Services, CMS. That kicked off a federal public comment period that went from September 19th through October 19th. That then, with that window closing, kicked off the negotiation of the different terms of this opportunity. So essentially, what the New York State Department of Health and the Centers of Medicare and Medicaid Services, CMS, have been going back and forth and working through, well, we've asked for 13.52 billion. Well, we're willing to do this. We've asked for this component. Well, let's talk about what that really entails. All of those different things have been negotiated for the sake of what will this actually look like moving forward. And lastly, they had this target implementation date of January 1, 2023. As you might imagine, with me talking about all these things and saying there's a lot more yet to come, they have not met that January 1 start date. And so we could get an email in the next 5 minutes saying that they got the green light. We could get an email. Right now, there's a lot of trying to understand where things are at. If I were to have a magic ball, I would say that things are probably going to happen in the next several months. But a lot of that's still just speculation, trying to understand where things are at and moving forward. The key component of this right now is that they are negotiating the terms of what this is actually going to look like. And when they do give the green light, if and when, that will then produce, like I said, these things called the special terms and conditions, and it will have an awful lot more information as to what this will really look like moving forward. So this is where we find ourselves. Why should we be involved? Maybe you're scratching your head and saying, all right, well, that's all great, but why? So these are all Scott Emery. This is not the state talking. And so I can differentiate some of those components. I really do think that, and I've been saying it throughout all of this, that 1115 waiver is an opportunity for us to have a hand in creating the future we want, not have it handed to us. What I mean by that is that not only do we believe that all of these things are connected, interdependency is how the world works, collaboration is the nature of the game in life in general. If those things are true, we also believe that it's true that we might have different trends, we might have different data analytics, but that the future is not yet, there's no data on the future. So what that I think gives us is an opportunity to actually create and think about how do we have a hand in what that would actually look like. And so when I say things like, how do we meet the thing from the top down, from the bottom up? How do we actually begin to understand what the community needs are in front of us? How do we take the decades worth of trust that we have built into our communities, which I guarantee is present on this call? How do we begin to actually move those things, leveraging this 1115 waiver towards what we want to accomplish? So I think we can have a hand in creating this future. Also, there are tables that are being set and that will continue to be set that you will be able to represent your served populations at. There are an awful lot of things that have taken place in this state, for good, bad, and everything else in between, that did not necessarily allow for the served populations, especially when it comes to the social care needs sides of things, to be represented and having a voice at that table. So if this is going to move forward, how do we do that for the sake of having those voices heard and being represented? Further collaboration for the sake of the community. There's an awful lot that's already taken place around these things. There's an awful lot of relationships that people are probably even looking at this call and seeing, oh yes, I know that person. We do this all the time. These are the kind of things that we want to begin to continue to enhance and move forward, because there are probably all sorts of different realities that you all have decades worth of wisdom and experience in that perhaps others don't, or perhaps that others aren't even aware of just yet. Those are the kind of things that, especially in the last few years of COVID, there have been silos that have been even further entrenched. And how do we begin to think about furthering collaboration for the sake of the community? I've been saying this the entire time, but I think leveraging 1115 waiver towards what you want to accomplish, not the other way around, comes from the sense of why should we be involved in this? Because there is work to be done, whether this thing happens or not. And so how do we think about identifying what it is that we actually want to accomplish? What are those dreamed about futures that we want to get to, and how do we begin to continue to push towards that? And if 1115 waiver happens, it will be a huge boost to what those desired futures actually look like. Gain insights into systemic issues at the community and regional level. There will be an awful lot of, there already is, movement and understanding those things. The data analytics and the future of what that could look like is going to be integral to moving all of this forward. just in the same kind of vein, moving potentially towards sustainable funding and BBP and away from grants, etc. I think is going to be another key conversation that we need to be keeping an eye on. And if the tables that are being created, I think are going to be created, are going to be really focusing on that, that's a key place for participation and staying a part of this. And then lastly, access funding for building capacities. That if that social determinant of health network comes into being, funds will flow to that and to individual community-based organizations for the sake of moving all of this forward. And so how does that come into being and what does that look like? So if any of this seems like a reason to be involved, I think that there are some key questions to be asking that are all connected and thinking about previous experience and asking an awful lot of questions about what does that look like, present capacity of who's staying on top of these developments, how active are you in the social care and health related social needs world of the community, collaboration potential, what tables are we setting for that, what tables are we being invited to, how do we make visible the systems and the networks that we're already a part of. If a system or a network is comprised of elements, relationship aimed at a common purpose, how do we begin to think about that in a tangible way to identify what are some of those leverage points for us to move forward with? And then lastly, and certainly not least, how do we begin to think about our existing network of trust? If we're able to make visible what's happening and who we're connected to, it's easy enough to identify the elements organizationally. There's this one and that one and all those. But then how do we think about the relationships between them? Are they ones based in trust? Are they ones based in fear? Are they ones based in veiled collaboration that's actually competition? Lots of different questions along those lines. But how do we think about what's happening in our network of trust? Because success will be found where those networks are made visible and expanded. So if we're willing to ask those kinds of questions, I think it starts with questions, then I think, okay, what are some actions that we could or should be taking to think about our next steps along this path? I think one, dream of the futures your community needs. I'd be willing to bet all of you are easily able to identify the groups that you're serving, the different needs that are prevalent, the different things that are emerging, all those different things. I think oftentimes we find ourselves, and perhaps even I've seen people talk about, thinking about what yesterday held as far as MLK. He didn't say, I have a plan. He said, I have a dream. So how do we start with thinking about what are those dreams that we have for the futures of the communities that we're trying to serve? If this is a systemic thing, which it is, how do we begin to strengthen ourselves? Because as a system, we all play a part in either hindering or enabling the system that we are a part of. So how do we start to strengthen our own organizational vision and aspirations? If we're thinking about the community and dreaming about what its needs are with the community itself, how do we then say, okay, yeah, we're a part of that. We are a component. We are an element that has relationships aimed at a common purpose. How do we actually begin to strengthen that and make our own aspirations and vision visible? Make visible your networks of trust. So if we're thinking big, what's the actual community? What's our role in that? Who are we connected to? How do we begin to think about that in a much clearer way? And then lastly, dive deeper into the specifics of 1115 waiver. The stuff that we've talked about, I've talked about for the last 40 minutes or so. There's a lot there. There's a lot more still yet to come. There's still stuff underneath some of those details. I'd be totally down to have more conversations about all of this if that's needed. We're having conversations about this all over the state. We have been since August of 21. Again, I'm not an agent of the state. And so part of these conversations is truly wanting to see things like systemic equity and community resilience come into fruition and be more real and enhanced. So take deeper dives into the 1115 waiver specifics, but I would say only after you have dreamt about the future your community needs, understanding your own organizational vision and aspirations, making visible your networks of trust, and then begin to think about, all right, how do we leverage these specifics towards those different ends? So key questions, key actions. I'm going to stop and hand it back over to Lori.
I did it. I unmuted. after this long, we should be faster with that. But thank you, Scott. It's a lot of information, as we said, so hopefully you all are digesting it as Scott goes. There's questions obviously coming in on the chat, but we have lots of questions, and you all will remember you filled out a pre-webinar survey, and we also have so we've got questions that we hope you'll include in the chat as we continue to have the conversations, but we have questions that came in ahead of time. And we also have a number of folks with us who are following this legislation closely and have offered to assist Scott in answering your questions. Joanne Caswell is somewhere in this screen, and we'll pin her to the top in just a minute. She's the CEO of Families First. And for those who don't know, they offer a wide range of programs and services that meet the needs of families who have children with physical and behavioral health concerns. We also have Katie Cook today, who's the Director of Partner Engagement at Adirondack Health Institute, which is a nonprofit organization that supports hospitals, physician practices, behavioral and health providers, community-based organizations, and patients and others in our region to transform healthcare and improve population health. So we'll kick off with some of the questions that we received in advance, but perhaps by way of kind of introducing those questions, I'll share that also in that pre-webinar survey, it's less than 13% of organizations joining shared that they knew they'd consider playing a role as a hero or a social driver of health network. And so perhaps that is an introduction to one of the questions that came in ahead of time. And maybe Scott, I'll let you answer first, but certainly then Katie and Joanne jump in as well. But the question was, what should potential heroes and SDHN be doing now to engage community-based organizations for their participation? Scott, do you want to start us?
Sure. So I would refer back to the slide that I had up there a second ago, as far as those key questions and key actions. I think just like individual organizations, if different groups are thinking about potentially pursuing that designation around the Health Equity Regional Organization or Social Determinant Health Network, I think it's the same things. I think it's how do we actually begin to dream of those futures, strengthen organizational vision and aspirations, make visible networks of trust through system analysis and things along those lines, and then diving deeper into those specifics and thinking about, do we have the capabilities, thinking about responsibilities, a lot of those different components. I think if there is desire to think about what that looks like from the HERO or SDHN perspective, I think it's the same thing. I think that there's a lot of different questions heroes and SDHN should be asking themselves, such as, if this entire program is aimed at reducing health inequity, how do we actually understand how we either further health inequities or are attending to those in the right ways? They can't be organizations perpetuating health inequities themselves if their own mission and goal is to reduce those different things. So I think it's essentially the same type of actions: dream, strengthen, make visible, and take deeper dives. And then I think stay on top of what's happening 1115 waiver specifics, because that will allow those different assessments to take place.
Great. Katie, do you any thoughts on what heroes or SDHNs could be doing now to engage community-based organizations for participation?
Yeah, I think, you know, AHI as well as we have partners all over the North Country, but we work really closely with the North Country Initiative and Fort Drum Regional Health. And while I haven't been in every single conversation that's transpired to date, I know from our perspective, we've been having a lot of conversations with different organizations and agencies, coalitions that we historically have not interacted with, at least from a district PPS perspective, because that is, you know, part of what AHI was known for. And really trying to shift our mindset into how is this waiver different from our experience as a PPS? how can we learn from these agencies, what their contributing role and impact is in the different objectives of the waiver. So we've been on more of an exploratory journey, trying to canvass the region, find out what work is being done, what we can learn about, you know, the health inequities that exist, how they're currently being addressed, and kind of set up those conversations for a potential future application. From a CBO perspective, I do a lot of work with some smaller CBOs in the region, and really just having discussions around, you know, how are you looking at operationalizing the services that you offer? So, you know, do you have any sort of data capabilities, billing capabilities? Are you looking at how to build those out, even on a small scale? What are the payers looking for in this? And we're having those conversations too. So it's really just been a lot of back and forth dialogue with agencies that we typically have not interacted with.
Great, thank you. Joanne, thoughts? Thanks, Cecilia.
Everything is still, you know, so up in the air, like Scott was talking about. I think, you know, we don't even know if it's going to get approved yet, but assuming that it is, I know there are players in our region who are thinking about being a hero or an SDHN. You know, one thing I would caution all the small players on the screen, you do have to have the infrastructure and capability to be one of those organizers. So, you know, I can say for my organization, we're not looking at that at all. But we definitely want to be at the table. And I think for all of you on the screen, it's critically important to be at the table. And I don't mean this negatively, but, you know, with DSRIP and past initiatives, most of the money has gone to the big hospitals, the big players. And we are all the ones doing the social determinants of health work in the community. And we need to be represented. We need to get the money. So you'll hear me say that multiple times, but if you have any ability to be at the table, please do so.
Maybe I can chime in here with another question that we have, and it's really on that line of how money will move. To Joanne, Katie, Scott, how will funding get to organizations doing the work? Will money go to existing organizations already working on social determinants of health? Will money be used to create new organizations? Will we have to start billing for Medicaid? What are the possible paths that we could start seeing some support?
So there are some higher level details within the documentation itself as far as how money will flow from the DOH, the state, to different organizations like the HERO, SDHN, different funds flow to the managed care organizations. How it goes from there, as I was saying earlier, there's not quite enough detail yet to have a clear line of sight on the flow to individual organizations or some of the reasons why. There are some assumptions that are perhaps close to what took place in the world of DSRIP, but right now, a lot of that would still just be speculation.
Yeah, I would agree. There's not a lot of detail on the funds flow. Really, I've been paying probably the most attention to the HERO funding, and you know, the HEROs are not going to be receiving and distributing funds the way it was in DSRIP, but more just the limited planning grants, which Scott alluded to earlier in his presentation, and what those planning grants will look like and what the deliverables will be remains to be seen.
Oh, Rebecca, do you have a question?
Yeah, just something, Kate. When Scott was doing the presentation talking about the regions and that the state hasn't yet completely determined the regions, that's my impression. I have a concern. First of all, I'm the CEO of North Country Home Services, and we provide home health care mostly to the Medicaid population in mostly Franklin, Essex, Clinton, Northern Warren, and Washington. And what we found within the agency is the region, it's very difficult in our remote rural region to be kind kind of put in with a huge area, St. Lawrence and that area. And my concern specifically for the Adirondacks, if we're talking about that today with the Adirondack Foundation and certainly surrounding areas, that we make sure that we have a good voice, because it's easy to get overlooked. And our biggest issue right now is workforce. There's a huge need that's not being met for the Medicaid elderly population for services in the home. And we have a lot of data on that, both from our aides and from the electronic verification system that we use. But my concern is that the region that we're in, Region 4, it looks like, is so huge. And I realize the population may, match with some of the other regions because they have to expand it, but it's very, very difficult to look at that whole area and really come up with, plans and systems that will work for everyone. Because at least in the experience that I've had over the last 40 years, it's pretty different. Our needs sometimes in the Adirondack Park are extreme and sometimes a little different than you might get in Plattsburgh or Malone. For instance, our workforce shortage is an absolute crisis in the Adirondacks, with about 1,000 hours of care a week just in the Adirondack Park not being provided, whereas Plattsburgh and Malone area, where we kind of hold our own, there's certainly a shortage, but nothing like here. So that's just my comment. I'm concerned about the regions.
Mm-hmm. Mm-hmm.
Yeah, no, thank you. I think there's a lot of truth there, and things certainly to be discussed further. Yeah, thanks.
Yeah. And I'll add, Rebecca, I agree. So I think that's part of the reason that 80K Action and the foundation wanted to make sure, we work with so many community-based organizations, at least across our regions, that, when we started hearing about this, and given that it's new, bringing so many or ideally that so many community-based organizations will have an opportunity to participate. That was really some of the driver for having this, and I see somebody asked in the chat, for transparency's sake, who supports Scott and bringing this information. So for us, it was, Scott, MS Hall is not in a position to participate in this in any way other than educating folks. So, it was our two organizations that brought Scott to have this webinar. Scott, maybe in a minute I'll ask the next question, but you can also share, how else folks are supporting you to bring this information forward. But maybe as you do that, I'll share also the next question. That one of the questions in advance was, are there criteria for 1115 eligibility to help assess if we're eligible as an SDHN participant or lead, and are SDHNs related by programming? So will there be a social determinant of health, SDHN for housing, for mental health, will they be programmatic? And how do folks know whether their organization is eligible?
So as far as the second part of that, there will not be, to my knowledge, specific, like domain-specific social determinant of health networks. I think that's a great question, thinking about what does that look like. There very well could be, subsets within the social determinant of health network that are focused on specific domains, but a lot of that is yet to be seen. As far as eligibility, if you're thinking about becoming a lead within the SDHN, there certainly are those pieces of criteria that I talked about in the slide, specifically to the social determinant of health network. But I would certainly, if you're thinking down that path, I would encourage you to take the 1115 waiver documentation as we have it and just begin to really parse through, again, thinking about some of those details after some of that other work is also done simultaneously. But there's certainly the ability to crosswalk organizational aspiration and vision capabilities with what we know as the SDHN is being framed out as at the moment. And then as far as individual organizations eligible to participate, that's all still yet to kind of be determined, and thinking about what's next as far as things along those lines. But I guess I would look at this from the perspective of understanding our own capabilities and vision and aspirations as an organization as we await some of those further details. Because if there's not, without getting too far into it, I guess I would say at the moment, I think that everyone should be thinking about how they do participate, because you already are. And how does that actually look? How do you actually begin to think about that, perhaps in more collective ways, which is still part of yet to be seen. But I would say think about it from the perspective of we will play in this because we are already attending to those social care needs of different variety.
There's also a mention in the chat of being sure your organizations are vendor registered with the state of New York in order to be recognized as a vendor. I don't know, Scott, Joanne, Katie, if there's thoughts about that. We may have community-based organizations that are not registered with the state. So just in terms of operationally, is that important? Thank you, Anne Russo Holland, for the comment.
Two other questions I'll pull from the chat are from Devin. Curious about the probability, if you were to look into that crystal ball again on this, of approval, and also what's the best way for our community-based organizations to stay informed about progress on the developments of this waiver?
Sure. So for the first one, so years ago, I was in a big meeting and they were talking about things like probability of X happening or Y happening. And somebody looked down the table at me and said, Scott's an actuary, let's ask him. And I was like, no, I'm actually not. And so I would say anything, honestly, would just be speculation at this point. I think the likelihood of this happening is pretty good. If I were a betting man, I would say odds are it will occur. Again, I think that there's work to be done, whether it happens or not. But I would say the likelihood of it happening is better than not. As far as further information, there are certainly different channels. I could certainly be a conversationalist if we needed to. Lori and Sawyer can continue to point people in different directions. But yeah, there's lots of different avenues I think that are out there. We can certainly talk more if you want me to continue to think about what those could look like.
There was also a recent interview that was done between Courtney Burke, who's at the Rockefeller Institute, and Amir, who's the current Medicaid director. I have the link for that. I can put it in the chat for anybody who wants to listen or read the transcript. But Amir was saying that he's thinking it might be a 4-1 start based on what he's been hearing internally. But again, speculation. I certainly don't want to go on record saying it will be April 1st. It's just a more recent development.
Great, thank you. This might be a question for Joanne or anybody else who is participating in a children's service organization, but the question was, what impact does this have on children's services? So to what extent, and I know, Scott, you went through some of the details, but to what extent does it address healthcare for young children, such as allowing value-based payments or funding for family service coordinators and navigators?
I think, Scott can answer probably better than me, but I think to me, it's getting the money to do the social determinants work, right? So my agency is primarily Medicaid funded, and I will say we get decent money to do work for, high risk kids to keep them at home instead of being placed. But there's always that little thing, does the family have fuel? Do they have food? Do they have a car to go to appointments? All that stuff that we all deal with all the time that's not paid for by Medicaid. And I certainly understand that Medicaid is a healthcare insurance and you don't want that mixed, but I think if anything was learned by the big hospitals and the big players in DSRIP was that they needed these community-based services. A lot of times people are hospitalized psychiatrically. Obviously, there's an underlying mental health issue, but many times they go to the hospital because they're cold or they're hungry or they want to sleep in a bed. And I think during DSRIP, the hospitals finally realized that we could save them money and save, the clientele's the heartache if we could deal with those issues and get paid for it, because, none of us want to search for grants every hour of every day. that it would then translate to saving money because they wouldn't need to go to the hospital. And I think everyone knows, you know, it always comes down to money, and that's a reality of the world we live in. So I'll stop there and let Scott answer.
No, so I think that some of that, I don't want to sound like a broken record, some of that still got to be seen. I know that there were different components that were not included in the initial versions of back in August of 2021, public comment period, different organizations specifically focusing on family and children's services very much spoke up about a lot of those questions. And so it was included in there, thinking about the representation at the Health Equity Regional Organization table, if you will, specifically calling out those organizations. But I would not at the moment have anything beyond what Joanne just spoke to. So, yeah.
I'm wondering, Scott, if you might lend a little bit of insight from what other states 1115 waivers have illuminated based on how this might unfold at the outset, if there is something to be gleaned from it.
Sure. So I think one, there have been states in the last, what is this, mid-January? So we'll say the last like 3 or 4 months, whatever time is these days, that have been approved. Almost all of them have had a focus on, if not exclusively, health equity and some kind of social care needs lens. There have been some that have had a very specific focus due to like their state's composition, populations being served. I think that if anything that we can pull from some of those that have already been approved, again, if you look at like Massachusetts, for example, or Oregon, but Massachusetts had some different components taken away. We're a very different state than Massachusetts. We're a very different population base than Massachusetts. So there are some of those different things that I think are hard to compare apples to apples. I think if there's one thing to pull away from just kind of large picture is that every state is trying to go forward with some form of value-based payment, attending to social care needs in one way or another, and thinking about these things from a collaborative, systemic perspective. That's where New York's been trying to go for the last several years. That's where the feds are trying to go. Again, I think it's how do we actually do this in a way that allows for us to think about those things from the bottom up, and really importantly, meeting the nuances of what regional and community needs actually are. But I would say if there's encouragement, it's all the ones that have been passed have had comparable areas of focus, collaborative, social care needs, pushing them into perpetuity via one mechanism or another. And then some of the nuances, again, it's hard to necessarily articulate what level of influence that may or may not have here in New York.
Great. So another question for organizations that are new to, if DISRUP is a new acronym and now the 1115 waiver, can you clarify, Scott, the population these programs will serve? So must they be Medicaid enrolled or eligible? And kind of a follow-on question to that is, will I need to start billing Medicaid or join an IPA?
So this is a Medicaid program. I think the second question, not necessarily. You don't necessarily have to do either of those. I think that, again, thinking about what it is that you are trying to get to and how does Medicaid billing serve what you're actually trying to accomplish is a key question. I think secondly, if you are recognizing that there are the benefits to being a part of different things like an IPA that might do Medicaid billing on your behalf, or at least lend towards those different things, that those things, if that's where you're trying to go, I think that would make an awful lot of sense. They're not necessarily things that you have to do, but it would seem like that might be beneficial depending on the aspirations that you as an organization have. If you haven't, I tend to speak in a lot of ways because I think each individual organization is trying to accomplish what it's trying to accomplish. How that fits into the bigger picture is something that needs to be investigated. I certainly don't want to give prescriptive answers to some of these different things, because I know we've worked with organizations who have been trying to make some of these different moves into Medicaid billing, into value-based payment, things like that. And it really just depends on where you are at in the life cycle of your organization and how those different components help you meet the needs of your patients in very specific ways. If it's not advancing the betterment of systemic equity and community resilience, I would say there are other options that are out there. Those are all like the very specific questions that I would certainly encourage organizations to dig deeper into. But I would say at this point, it's hard to be prescriptive not knowing a lot of the bigger context.
Yeah, I mean, that's what I was going to say as well. Until we have a better sense of how the money will flow, I think it's hard for small agencies to figure that out. Families First is a member of the Northwinds IPA, and we chose to do that specifically because we wanted small behavioral health organizations to be at the table, like I talked about before. We are a registered vendor of New York State. I think that's not hard to do. And if you think you're going to get state grants, that's something you could do now. But I think we need to wait and get a better handle on how the money is going to flow, and then you'll know what you need to be part of or registered for, et cetera.
And I would say to that first question too about the Medicaid population, it's certainly, this is a Medicaid program, and so there will be Medicaid patients that will be the focus. But again, I think thinking bigger, I'd be willing to bet that your community, when it dreams about the desired futures it wants to see, is not dreaming about them through the Medicaid lens. And if that's the case, then I think we need to start thinking about what are those desired futures that leverage things like that towards those ends, not the other way around. There's a lot more I could talk about with that, but I think how do we potentially think about these kinds of things beyond what card people are carrying in their wallet?
I'm curious, if this waiver is to pass, is it something that will expire? Is there a renewal needed? How long could these kind of resources last?
When does the bread go stale? Great question. To be honest, it's right now being proposed as a 5-year window. There are different components that are called out in the documentation about, hey, we'd love to see some of these things be sustainable and move into the future. What that looks like mechanically, how that would work, is not quite spelled out. And so unless negotiations that are happening between the feds, CMS, and the state dictate a different timeline, it will be at least 5 years. But then from that, that's sort of a, let's see what comes about. But at least 5 years, which really, again, is really scratching the surface as to how we're going to address these different things happening at the community level. 5 years is not going to capture all the things in the world of, say housing. One of the projects that we helped build out was a housing trust fund. I think I might have mentioned that earlier. And just quantifying the amount of money needed for housing in one particular city, $13.52 billion is going to barely scratch the surface of a lot of those things. So all to say, don't know when it would end, but at least 5 years is what they're looking to do right now.
I also think part of this is that there's going to be more organizations involved in value-based contracts. So if those outcomes show success, then the managed care plans will want to keep making those investments with the social care providers, because the overall total cost of care is going to go down, which means they're saving more money and they're going to continue integrating those social care providers into the bigger delivery system. So that's another sustainability mechanism.
Exactly what I was going to say, Katie.
Thank you all. Are there any last questions from anyone on the call?
I have one more. I guess that's just kind of anticipating and trying to focus on preparedness. Can it be anticipated how much individual CBOs will need to kind of beef up their data collection and IT infrastructure versus how much of that will be held by either the social determinant of health networks, or is that something to start looking at IPA networks that could potentially house some of that? Because, you know, as exciting as some of this is, having a foot in some of the HIPAA world and just all of that compliance, it can be kind of crushing as well. So like, who's holding that complexity in these arrangements?
Mm-hmm. So I would say all the above to that, as far as understanding what data components you are already collecting and how are you going about doing that. I would then say also looking at the collective level as far as an IPA, what are the different offers that different organizations like that can bring to the table? There's not right now enough information known about what the SDHN will be working with or what that looks like. There are certainly referral platforms that do exist that are out there of different flavors. And so I do think it's kind of all of the above. What are we collecting? How are we doing it? What are we waiting on as far as some of the clarity for these different groups as SDHNs? There are organizations, to your point, like IPAs and others that are doing some of this work on behalf of in a collective type of agreement. And so I would say beginning to look into all of those is probably a good next step while we still wait on some of the clarifying parts of who might be responsible for X versus Y.
I think one thing I would add, Devin, to that at my level, when I've been sitting at these tables, I've been trying to make them very well aware that the reason some of the small not-for-profits are good at what they do is because they can be nimble, right? They don't have to have a compliance officer and they don't have to have, you know, a billing department and all that. So just trying to get them to understand that if we figure out a way to get you money and let you do your job, you're going to make a difference with, you know, minimal data reporting. So who knows where that's going to go.
Thank you, Joanne, and thank you, Katie, and thank you so much, Scott. I'd like to give everyone who shared their expertise and information today a big virtual round of applause. And as a reminder, we're going to send around your slides, Scott, today's recording and our contact information for the three of you, so long as you're willing, and we'll send out some of the additional resources that were shared in the chat. Thanks to those who populated those. And now that we all have this information in hand, I hope it really positions us to have some follow-up conversations so we can lean into that dreamable future, so we can think about collaboration, because there's so much more work to do. Lori, I'll turn it back to you.
Yeah, I would say, just share with you all that not just on this, but you will, the foundation will be probably reaching out to you again in the near future. They say timing is everything, but just prior to, and actually some of the reason for our conversations with Scott are that we were funded to do a study called Strengthening the Social Safety Net in the Adirondacks. And our intent with that, like I said, we'll be reaching out to you because our intent is in the first phase to kind of consolidate the needs assessments that already exist. We know there are many, to look at the gaps in service in our region, and then also importantly to do some relationship mapping. So to Scott's point about strengthening the networks of trust, and I really like what you said, that progress and collaboration work at the speed of trust. We would agree with you, and so this will intend in this state of the social safety net to also look at these networks and how people are working together. And then our step, pre-learning about the waiver, our next step was really to take the information that we learn and work with all of you to help strengthen, what already exists that is good, and hopefully fill in the gaps, help not just us, but everybody to work on filling in the gaps in service. So, ideally we learned about this kind of in the preparation for doing this study, and the great thing is I think that it will help both. We'll be able to either leverage 1115 if it passes, and this should give us more information to do that. And if it doesn't, we'll be all the more ready if it comes up in another year or so. So more to come on that, and certainly in any way, if we can work with the ADK Action to facilitate more conversation, should you want it on the waiver.
With that, thank you everyone so much for coming, and have a good rest of your day.
Thank you.
Thanks, everybody.